Okay, perfect. So here's the link. You can share, guys, on your social media. It's in the private chat. So pretty much the rest of the people is actually able to join us via link on YouTube. Can you see it?
Yeah.
Okay, perfect. So we are live, and that's perfect. Okay, so what I'm going to do, I'm going to pull the rest of the people temporary out of stage. Just it's temporary. You still can ask questions, guys. Give me a second. Remove. Kimberly, remove. Yes, that's better. So can you hear, see? Everything is okay? Frederick, can you please sit a little bit? We can't see you.
Everything's good on my end.
We can see only part of your eyes.
Yeah, anyhow, sorry, I was looking, I was sending the link around.
Yes, so let's get started, because I believe the best way to do it is just keep conversation going and just ask basic questions and discuss the most important things, because the entire idea EEG in psychiatry, that's such an fascinating subject matter. There are so many search in the Google, so people really looking for the subject matter. Moreover, I was constantly asking, like personally, from different like managers from clinics to make a workshop related to EEG in psychiatry. So we're here with Dr. Boris Goldstein, who is actually a big part of his life dedicated to EEG, right? And Dr. Boris Goldstein has amazing experience in designing, working on different designing EEG, working different type of projects dedicated to measuring different type of metrics with different type of outcomes with different type of reasons, right? So Dr. Boris Goldstein has amazing experience in terms of EEG, and Dr. Frederick Starr with us today. He is actually a great neuro psychiatrist. So he's been using EEG in his practices, right?
I've been developing different types of ways of reading the EEG for about 2 decades. I've been working with EEGs for about 35 years.
Amazing.
I've been a psychiatrist for 20 years.
Okay, so let's a little bit start from a very basic general question. When do you think EEG is actually most relevant to use in the practices of psychiatry? When is the best time? Does it make sense? Okay.
Probably we both have similar answers.
Go ahead, Frederick.
Well, for me, it's part of the initial diagnostic workup. So I can't get a full picture on what's going on with my patients until I look at their brains.
So you're actively using your EEG in your current practice, right?
I'm a psychiatrist, medical doctor, and all day, every day.
Okay, so when do you use very specific? What kind of device do you use? First of all,
say that again.
What kind of device do you use? What kind
of our system, which is called ANA, Advanced Neural Network Analysis. We currently have 3 U.S. patents on it it uses machine learning and clustering of the EEG. So it's device agnostic. We can take in any EEG that's in the proper format and is clear information. In my own practice, I use a couple different systems.
Amazing.
It doesn't.
Okay, let's then start with the diagnosis. When a person comes to you, the first time visit, how do you apply EEG for diagnosis? Just general question.
Boris, do you want to? Dr. Goldstein, do you
Yeah,
want to?
I think I would like to add to Frederick from EEG point of view. EEG been discovered over 100 years ago, so it's not a new device, and it's a lot of use of EEG in the medical practice, from seizure detection, rapid EEG, long-term monitoring. We see now a lot of like 20 or 30 years ago, we see a lot of development of using EEG not only for brain assessment, but basically for tune-up. So you can see constantly brain assessment and you can see monitoring. So what we've seen mostly using our EEG in a capacity, as Frederick mentioned, for brain assessments. And when we see what's going on in the brain with open eyes and closed eyes and under the load, when you have a brain under the load, and we see brain performance. And then you can create different protocols for neuroplasticity using neurofeedback, and we tune up it like on a monthly basis or in a period of time, which allow you to do brain assessment constantly, so you can see not only a snapshot what's going on the brain in the environment, because every time that you're doing brain assessment with EEG, you see it's a specific time and specific condition of the brain. So it's calibrated by itself, and you can see condition, but you can see performance of your brain, and you can see where your patient or your users is improving or doing any changes in the brain or behavior.
So let's start with the moment that we have different type of audience here. We have people who have multiple experience. We have people who actually know what to do with EEG. We have people who have no idea how to start finding the right device, etc. So let's start first with very basic questions. Okay, so let's put it this way. I'm a psychiatrist. Okay, and I've heard, I read articles that it can be really interesting, and really has a lot of practical sense. So let's focus on what is the best way to approach, how to find the right equipment. We know that we have nowadays, and you probably aware, there are so many devices, there are so many companies actually designing EEG in all possible ways. There are multiple ways that track information. There are multiple ways that, there are sensors that cover specific parts of the brain. So let's start with the question, how to find the right device, the right brand, how to approach it?
I can tell from my side point of view what people are using to choose a device. You're looking for how many, according to 1020, you're looking for how many channels that you want to have a brain assessment. Is it 1 channel, 4 channel, 8 channel, 21 or more? You're looking for quality of the signal and impedance that you'll be using from electrode point of view. You're looking, are you using wet electrodes, gelled, or using dry electrodes point of view? You're looking for capabilities to do remote monitoring or on-site monitoring because of your task. And you're looking for affordability as well, because EEG before, like 5 or 7 years ago, when manufacturing EEG was very expensive. Currently, as you mentioned, it's a lot of competitors in the space with different electrodes and different use. So you're looking for affordability, quality of the signal, number of channels, and use of proceeds.
Well, if we will go online, we can see like really simple things, really affordable one, and we can see, of course, more sophisticated, like scientific devices. Of course, the quality, we know the quality will differ, but still, I understand, even simple devices can bring a lot of sense, right?
Of course.
Of course. So let's focus on it. Say it again?
I don't agree.
Go ahead.
I think that there's many devices on the market, and I'm not going to single any out, but they don't have the signal quality, reproducibility, usability that a clinical system would have. So I would strongly delineate or differentiate between medical grade neurofeedback, which is what we do at our medical clinics, from do-it-yourself systems that are off the shelf and they don't sample at enough high enough rate, or they're susceptible to sweat, movement,
Artifacts, a lot of artifacts.
dropping of signal. So I don't think they're created equal, and I don't think that any old system will do.
Yeah, I kind of agree with Frederick, because from clinical medical point of view, quality of the signal, impedance, potential allergy of the skin, or is it a dry skin or the wet skin, is the shampoo, what kind of hair your patients have, is a thin one, braided, so it's a lot of different combinations. So from clinical point of view, quality of the signal, artifacts, and all kind of software adoption of the signal, it's very important.
Okay, let's talk a little bit about artifacts, because we actually have created a presentation, of course, just to be sure that we're covering all the subject matter that could be, interesting. So anyhow, let me put it this way. Let's talk about artifacts. What kind of artifacts can actually exist? We know that it can be eye movements. Boris mentioned hair, sweat.
Like you have here, eye movement, eye blinks, muscular, cardiac, electromagnetic frequency from the outside. So that can interfere sometimes. Boris, what else can you think of there?
Also movement, clenching of the teeth when you're crossing.
Right, swallowing, movement.
And all of it, yes, and all of it, okay.
Well, just for the people here that are new to EEG, so EEG stands for electroencephalogram, so it's a measure of the electrical activity that's in the brain. And we have to get through skull, and we have to get through skin, and also muscle. And muscle makes electrical activity itself when you contract your muscles. So that can interfere with the EEG.
Okay, so let's talk about chemical part of it. I know that if person has certain certain medication, it can influence big time. Dr. Frederick, can you comment which kind of medication? Because some patients, they can have specific medications. They can be on a specific medication. It can influence it can impact big time. Yes.
There's a long list of them.
A long list of them?
There's a long list of them. Steroids is one that I don't see on the list that has effect. And a lot of children and adults, especially in the United States, are taking stimulant medications such as Ritalin. Those have an effect. But I see here, I agree. I mean, benzodiazepines scream out on the EEG. It's quite noticeable.
Okay, so we have to for all of us who is new, we have to remember that the influence can be because of some biochemistry of your patient. Let's move forward. In terms of, we know that the basic signals that EEG provides, right? What we can read, what we can understand in terms of interpretation of the signal. We know that all the EEG devices, they're not made equal, as we discussed already, right? So the question is what for psychiatry? Okay, we're talking about psychiatry. Which one would be the best choice? Which devices, maybe some characteristics, maybe you can mention some brands, would be the best for the application in psychiatry? Maybe
Boris, you have some to mention. I don't.
Yeah, it is a complicated question. Of course, I'm biased. We are manufacturer of the devices.
Right. We're not discussing easy questions here. Just to let you know, it's EEG in psychiatry. It's so new. First of all, I believe we only one single who has actually decided to cover this complicated subject. It's very complicated. Nobody did it before, and it's very sophisticated. So we're not talking about simple. And if you have a little bit doubts in terms of your conclusion, just tell. We will check it out. But the entire idea, I think it's very important to discuss it.
Go ahead.
I just want to add to the previous discussion in terms of medication, because your brain status is unique at every single point. So for example, when we are using any protocols or brain assessment, we looked not only of intake of medications that you mentioned, but it's also level of your stress, level of your anxiety, how good it was sleep, what is your food consumption or water consumption. It's more complex just as a medication. Coming back to the waves, it's not a straight waves that you're looking for, beta, alpha, but you're looking for different ratios between alpha, beta, and the ratios showing you what's going on in the brain in specific part of the brain. Coming to devices, the Bluetooth 5.0 that been available just recently allow you to transmit substantial amount of data wirelessly. With EEG, you've been connecting to a bunch of wires and you put a bunch of electrodes, and it's taking technician to put EEG. What overall going on in the industry, because majority of industry go wireless, now you can transmit, like we are transmitting 21 channel via Bluetooth, so substantial amount of data that you can push either to your phone or to your computer. So, and it's becoming available, it's getting more convenience that you don't need, and also 1020 becoming more convenience that you can put, like for example, dry electrodes without really having very sophisticated technician. So everything is going the same with the iPhone revolution. It was a bunch of phones available, but somebody came up with the iPhone and other devices. The same going on with the industry. It's becoming small size. It's becoming more user-friendly in terms of application. So a lot of time you don't need to have a gel, for example, to put on a patient, and you don't need to know specific point because it's showing you. And it's getting more and more user-friendly. So from a device point of view, it's a lot of manufacturers of different devices, even medical quality. So what you need to take a look, what is the use case that you will be using and what applications that you will be using.
Yes, we're going to discuss we will going to cover a few several most important subject matter in terms of what you mentioned. Okay, Dr. Frederick, I would like to ask you a question. So you mentioned that not, for your perspective, not all devices actually, you basically consider only medical grade devices actually applicable psychiatry, right? So you think that
FDA approved.
Yeah. So you believe that if we will use something simple, order it online and use it just, very simple, basically limited in terms of measurement, that will be not accurate, that we cannot rely on it because there are so many artifacts, there are so many reasons that could prove us wrong, right? That provide.
I think so.
Okay, so yes, in terms of, let's talk a little bit about medical grade devices. In your practices, how many people you have? Do you have technician? How many nurses do you have to assist you in?
Well, so my company Myneurva, which is spelled with an Myneurva. Actually, what we do is we offer the medical grade neurofeedback to medical doctors in their practices where they can bill their patients, through insurance, so their patients don't have to take a lot of these large fees that I think are often associated with neurofeedback. So again, so you're asking a question. Internally in our organization, we have a number of clinicians that operate all over the world remotely and then work in the different doctors' clinics. So we have clinic in Hong Kong, Slovenia, California, Washington State, New York City, New Jersey, Tennessee. And so in these clinics, that's where our patients would go. So they would see the doctor there, and then we're offering the analysis as well as whatever treatment, not just neurofeedback. So medication sometimes, supplementation sometimes.
Yes, thank you so much for the information. Let's move a little bit. You mentioned brain assessment. It's always interesting the way how we can assess the situation. I mean, when I tried to find information online, I found so many different sources in terms of in terms of testing of the patient.
Right.
So what is your first time visit? How do you approach Like, what is the best, like, the approach to the evaluation, to the brain assessment?
Well, so I think EEG is an adjunct as a diagnosis in medicine. It doesn't make a diagnosis. I don't think any test ever makes a diagnosis. So it's part of a comprehensive history, often physical, often including, you know, neurological exam, as well as lab testing. And so, and also probably genome testing. So we want to get as personalized as we can for the patient's medical treatment. So it's tailored, everything is tailored for each individual.
So basically it's very individual.
Well, I'd say the results are individual and the treatment outcomes are individual, but the process is not.
Okay, so let's start with the first time visit. When a patient visits you first time, how do you approach it? Do you first give them some tests? Huh?
I say, what can I do for you?
Okay, yes. So for example, if a person comes with a specific issue, and person doesn't know, because patient doesn't know his own diagnosis, whatever, right? So in terms of, do you have specific tests, EEG related, that would be correlated, and you would find like that would show you a good picture of the brain situation? What kind of did you develop approaches specific to the tests?
Well, we can take a minute of EEG, and then with that minute of EEG and subjective information, come up with a probability ratio that matches a DSM-5 or a ICD-10 coding diagnosis. But that doesn't make a diagnosis. It just gives us a probability, a weighted probability that then gets weighed in with the other information. If a computer says you have ringing in your ears or tinnitus, and you don't have tinnitus, you don't have tinnitus, which is ringing in the ears. It is a diagnosis of symptom.
So you're going too far now, because tinnitus, it's an absolutely different direction, and we're actually, for some of you,
it's a big complaint, and it's amazing. It's a big complaint.
Tomorrow I have a workshop with the audiologist regarding tinnitus. So if someone is interested, please join us.
I think that we see, when we can see the tinnitus and identify that in EEG, I think using neurofeedback, we probably have 80 to 90% remission rate. So after 20 sessions with tinnitus.
So the thing is, we're here trying to focus on psychiatry. So
that's something that definitely affects your mental health.
Yes. So basically, when patient comes with a certain issue, sometimes it can be just simple tinnitus, right? Sometimes it can be just simple issues with the ears, right?
Well, I had a patient who had depression and insomnia, and we did a whole workup on them. It was actually a medical doctor, and then when we put them through the artificial intelligence EEG system, it said they also had tinnitus, and I asked them, "Do you also have tinnitus?" And in the course of the exam, it just didn't come out, and the person said, "Yeah, that's actually the problem, that I don't sleep and I'm depressed all the time."
Yes, exactly. It's a big part of it. I mean, I'm totally aware of it, that sometimes people have a lot of sufferings, in terms of mental, psychological health, and then turned out to be absolutely different thing. And that's. Thank you so much for mentioning it. Anyhow, that's why it's so important to have.
I think a common case that I think we can all relate to is attention deficit disorder.
Yeah, so that's why it's so important to have medical grade device.
I think so. Yeah.
Okay, and different type of professionals involved, because I don't believe that every single psychiatrist will be able to diagnose if there's some. You have to have a team of professionals with different type of background, because I don't think that one average psychiatrist will be able to address all possible issues. I mean,
no, I agree. That's why we work with medical doctors.
That's
yeah, okay. We have a whole team when we work with a patient. So we're just one portion of that, which is the brain health and the brain support.
Okay, let's discuss the idea of psychiatry first and foremost. So now if we're focusing on let's get back to the presentation. Mood disorders. Okay, so in terms of mood disorders, how EEG can be used and can be applicable in terms of like how you can test, how you can follow the changes in the brain, how the EEG information can help with the finding the right medication, and what is the how it can be helpful in the tracking of the outcomes. Can you comment on it a little bit?
I think I've been talking for a long time, Dr. Goldstein.
It's okay, Frederick. Your doctor's majority doctor questions.
Go ahead.
No, go ahead with the mood disorder.
I mean, here, one thing is I feel like, and I don't know, I'm going to ask you your question. I'm going to ask you on this. I think that a lot of times when we see benzos, they sometimes look like bipolar depression in that beta band. So there's a differentiating factor because we saw before that there was the beta activity in benzodiazepines, right? So I personally generally am looking at medications and other more accepted traditional treatments for bipolar, especially bipolar 1. I mean, maybe if there's other symptoms related to it. And am I getting an EEG? Yeah, because I want to rule out traumatic brain injury, which often presents, can present as mania or other things there. With regards to depression, I think that's evident, especially with alpha asymmetry, although I think I've seen some papers recently that have been trying to refute that. I'm not sure I agree with it. I think that is present, the frontal alpha signature in depression. So I think with medication use and seeing if the medication benefits the patient. So by using EEG, can track progress. By using EEG, it's possible to get an understanding of what medication might be not necessarily useful, but I'd say might produce side effects. So there's some EEG profiles in attention deficit disorder where stimulants aren't going to work as well. So, just speaking extemporaneously, that would be my answer.
Yeah, I think from EEG point of view, EEG by itself is not doing diagnostics. So it's a tool that you can use, and it can use for either assessment or traceability. For example, in our system, we made it open source. We have an open source SDK that you can create your own application, or we have an open source to create your own protocols. Every doctor have a different opinion in terms of what to diagnose and how to treat it. That's why we did it open source and get an ability for doctor to create their own protocols. I think with AI coming on board, it will be probably get more efficient, but the final decision anyway is by the doctor or team of professionals, because you need to think about in consideration one of EEG, but all another factors before you're making diagnostic or you're making a treatment plan.
So it sounds like we both agree that it's not going to be used as a standalone diagnostic instrument, but used in conjunction with good analysis and history and performance data and other data to then come to some potential conclusion.
Especially for this kind of mood prediction stuff or mood traceability, it is a complicated subject.
Mm-hmm. Did we lose our host?
I think so.
So I guess, what would you like to talk about?
I don't know what the agenda was from the host. They kind of
we were
like
just
agenda.
Talking. So
maybe
I'm not.
Maybe somebody has questions. You want to put it on the chat so we can refer to Q&A session with Dr. Frederick.
Good idea. And with protocols, I guess what you're saying is that the doctors can make their own neurofeedback protocols.
Yeah.
Right. What we're doing is network training. So default central executive or salient mode. I think we have a pretty powerful paper coming out on that shortly.
I'm sorry for the. Can you hear me?
Yep.
Yeah, we kept it going.
No, I can. For some reason, every time I'm doing recording, something is absolutely wrong. Can you hear me?
Yes.
Okay, perfect. But I can't hear you. That's interesting.
I hear you.
Anyhow, what about now?
Yes.
We hear you.
Okay, so let's discuss. Can say something again? Can you tell me something?
Hi.
Sure.
Because I can't hear you. It's interesting. So tell a little bit. I mean, can you hear me again? No.
Yes.
You can.
Okay,
I
hear you.
can't
Yes,
hear you.
I hear you.
I can hear you. Anyhow, that's ridiculous. So why it doesn't allow me to hear you? Because I can continue conversation without hearing what you're saying. Speaker. What about now?
Hear you.
Okay, perfect. Good. Finally. Oh my gosh, I'm so sorry. It's just happened. You know, every time I'm recording, especially
okay.
online, a million things happening. I don't know why. So let's talk about we discussed a little bit about mood disorders, right? So is there any, because I found some information that mood disorders can be very well seen in EEG in terms of like different brain waves. We know that bipolar patients, they have increased beta waves and decreased alpha waves. Can you comment, or do you have like any your personal experience? Can you comment on that? Like, do you have patients with bipolar disorders? Can we see significant changes in terms of like brain waves, in terms of like what we see on the picture? Even
I would
doesn't
like
matter
to
what kind of
comment
device.
on that.
Say it
I
again.
would like to comment on that.
Mm-hmm.
So in our database, in our ANA system, what I'm seeing in the histograms when we cluster the different, what we call a neurophenotype, so what the EEG looks like, we're actually seeing a high association in the patients that come to us with diagnosis of bipolar crossing over into traumatic brain injury, as well as post-traumatic stress disorder. So if you know the history of the original database acquisition for the category of bipolar in the DSM-5, the Diagnostic and Statistical Manual, those two things were not controlled. At least post-traumatic stress disorder certainly wasn't, because it wasn't around at the time. So I think that many people that are walking around with this diagnosis of bipolar actually are not. And I think that that's one of the confusing things in looking at EEG for bipolar, because there's been a lot of things in the literature describing what it might be and what it might not be. So is there a signature? Perhaps. There is definitely one, I think, that jumps out. But overall, I don't love that diagnostic category, and I always want to look at it closer.
Okay. But let's talk a little bit about, from my perspective, we didn't get the complete answer. Let's put it this way. I'm not satisfied with your answer.
I see.
The thing is,
that.
yes. So from my perspective, okay. So if you have I know that EEG can be really powerful tool in terms of like seeing unexpected things. Like as you mentioned, you have a patient and it turned out that the patient actually has an ISS, so you can discover something new, right? So if you have, like, for example, if you're speaking, when I was speaking with medical doctors with different, from different countries. I know that sometimes people, they treat patient with they're trying to treat him against one particular disease, but it turned out after multiple evaluations, it turned out to be absolutely different disease in the end, in the result, after using more sophisticated, more modern tools like EEG, MRIs, etc., in terms of like after brain assessment. So, for example, my patients, I'm treating, I'm working with a patient who has, for example, depression. Okay. Is there any way to see, like, I'm doing brain assessment. Is there any way to see, like, if we're talking about bipolar disorder, is there any way to like differentiate this disease via EEG? That's possible, like via specific tests or whatever. Do we know something? I know that's very complicated subject matter. We're still in the process of discovery. Just the question is, do we know anything currently? No?
I was waiting for Dr. Goldstein.
It's not my field. We are not doing diagnostics, so it's
Okay, I can talk to it. I can speak to it then.
Okay.
Depression is a multi-systemic disorder with multiple potential causes, including some to do with the GI system.
Mm-hmm.
So to think that we're going to look at the EEG and say somebody is depressed is really just doing it in a one-dimensional fashion.
Mm-hmm.
So is there a signature that I can tell a patient, yes, your brain shows that you are depressed? Yes, that exists.
What is the most
Frontal alpha
obvious sign?
asymmetry. Frontal alpha asymmetry, but it's complicated. So so there's a finding that we see which has an imbalance of alpha mostly towards the right, that it happens in 8 to 12 hertz or 7 to 10 hertz. That is a signature that if you look at that, you would say that to the person might fit the criteria under the MDQ depression testing scale for major depressive episode. But I mean, those people usually get better from SSRIs. I mean, we don't usually see them because they took a medicine and got better on their first try. Usually the neuropsychiatrists like myself are seeing people that didn't get better. And so there's more to it.
Okay, so let's thank you so much for
and mostly
for example,
mostly it's concussion.
Yes, for example.
Usually it's concussion, sometimes it's PTSD, sometimes it's environmental toxin.
Oh, really? That's great. That's good to know. So the thing is, okay, so you for example, you discovered something, you think you are right in the right direction, and patient get treated, okay, with whatever medication. So, and do you use, because this workshop is all about EEG, so we're going to cover the subject matter from different perspective with very basic questions, because I believe that's very important. Anyhow, for example, if your patient, you got specific diagnosis and you're working with the person, do you track the changes? What is your approach? Do you use the medical grade EEG to track changes? Like, do you track changes in the weeks, in the months? How does it work? Like, how often do you do this?
6 weeks. We track every 6 weeks.
Every 6 weeks?
About that.
It seems like a lot, no? So, and you, for example, what the major changes when they happen? Like, basically,
we have messy hair. Yes, we
only after like 6 months or so, or 6 weeks or so.
Well, with medication, you would expect it to take about 6 weeks to work. I think that just from a physiologic perspective, you're looking at a couple of weeks for the upregulation of DNA. You're looking at a couple of weeks for the transcription of RNA, translation, and then expression of proteins and new receptors. And brain neurons tend to grow slow. So 6 weeks is about the number we've come up with.
Okay. Do you making specific assignment to conclude that the patient is free of depression?
By clinical, that would be by clinical exam. I mean, the QEEG helps, but I always say, like, you can show people pretty blobs of colors getting better all day, but if they don't feel better, it really doesn't matter. So the proof is in their symptoms and the reduction of symptoms, and we track that using both gold standard pen and paper tests and correlating that with EEG. So I think we have something like 3,000 individuals as such in our database for depression.
Okay, good. Let's move toward depression. Dementia. I'm sorry. Because we know that dementia is like, it's the #1 neurological disease. I mean, it's growing. For some reason, there are multiple, I mean, I found at least like 10 different explanations why the rates, why we have so many people with dementia currently. We're not going to discuss this part, but EEG in dementia, is it useful?
I think so.
It is one of the tools again. So EEG is not a miracle pill.
No. I know it. That's why we're covering very specific subject matter. So I would like to know, like,
specifically, yes, it's one of the tools that you're doing toward to measuring dementia and measuring your progress. Also, from neurofeedback point of view, it is a lot of different techniques and games and audiovisual stimulus that you can use, and use EEG to see how the performance is in terms of concentration or training of the brain. And it's usually 3 to 4 weeks process that you can see the progress when you're doing neurofeedback.
And in terms of like, because I know that dementia, it can be, varies, and symptoms are varies. And the most important thing is to find out that the patient has dementia on early stages. And I know that there are multiple aspects of it in terms of like movements, muscle performance. And I know that EEG is actually perfect in terms of like evaluation of the muscle performance and like connection to the brain. And I know that there are multiple already research exists in this field. So, Dr. Goldstein, you mentioned really good thing about like you mentioned that there is a specific assessment related to dementia, right? So, we a little bit discuss what is the best approach? What kind of what would the best way would be assessment would look like? It's like combination different like cognitive, physical. Can you comment on it?
Yeah, once again, we are not doing any diagnostic or recommendations. So we are pure device manufacturers and software development that helps doctors like Frederick to make an assessment. So we are completely neutral, and we are not doing any medical recommendation or diagnosis. But we are using different devices, or we provide different devices for diagnostic, including EMG for muscle movements and heart rate variability and breathing. And it's all going in combination for doctor to make a final assessment. So I'll pass it back to Frederick because it's more medical question.
So that dementia, there's, depending on how you slice it, 4 to 6 different kinds. Alzheimer's dementia being only one of them. Frontotemporal or PICS dementia being another one, somewhat similar to Alzheimer's. Parkinsonian dementia, dementia pugilistica, which is from traumatic brain injury, as well as dementia due to cerebrovascular events, vascular events, multi-infarct dementia, Lewy body dementia. So, so using EEG here, to me, is integral in being able to assist an individual or their families in getting some more insight beyond what they're generally getting with traditional and just neurologic testing. I think that Alzheimer's dementia is something that can be seen and identified with QEEG very early, even 5 years, well, when someone's in stage 1. And I think that there's a gradient of changes. I can, if you want me to get specific, I can. I see decreased relative power theta in the central areas. I see hypocoherence frontally in the early stages, in alpha, beta, and then it seems to progress to what I call the butterfly pattern, where you see very specific ridges across both ears in the beta and high beta. And then as that progresses further to advanced Alzheimer's dementia, we see the same thing in delta and theta. So I think it's a wonderful, I mean, for psychiatrists, for a medical doctor, it's a fantastic tool for tracking.
Yeah, especially taking into consideration that you can find something serious on early stages. So that's extremely important. You really can help save basically people, right?
Well, I think that in those cases, neurofeedback, unless we're talking about stage 1 or stage 2, is not a standalone. We will, in some of our clinics, employ everything from neuropeptide infusions, which help with neuroplasticity, to stem cells, which also seems to help maybe reduce or slow the process. I think inflammation plays a very big role in dementia and brain function.
That's good to know. We know that that's very complicated subject matter.
I think that's what I said.
Yes, but it's very important to cover on what we have now, because that's very interesting, unique subject matter. Let's talk a little bit about addiction, because I know that we all know that addiction is actually a very serious issue. And we know that the numbers, statistics tell us that there are so many people in the United States and globally who actually suffer from different type of substance abuse, alcohol abuse. So, and I found out, I mean, I'm not like, you can consider me like professional in this particular area, but I found a lot of information regarding that. People that EEG signals, like you can find a lot of information regarding the situation in the head. If people has addiction, you can see it in EEG. Is it true? Can you, Dr. Frederick, can you comment?
If they are under the influence?
If they addiction, they have substance addiction.
If they're actively using, or if they're, well, like I can certainly tell if somebody's intoxicated.
Well, you can tell it.
I can also probably tell if they have a higher tolerance for alcohol or a lower tolerance for alcohol. I can see if somebody's acutely intoxicated with cannabis. We talked about benzodiazepines, which is also a drug of abuse. Opioids. Yeah.
So let's talk
but
about,
I don't generally get people that are getting brain scans usually aren't like getting drunk before they get the brain scan.
So let's talk about changes in the brain waves. How differ? How people with addiction, how their brain waves changes with addiction? What you can see, like a person is addicted. Like we're not talking about like temporal intoxication, we're talking about like long-term addiction. Okay, so what kind of like changes?
Depends on the drug.
Depends on the drug. But
yeah, I mean, if we pick alcohol, we're going to see. Do you know what connectivity is? It's the synchrony between the hemispheres or between the different areas of the brain. There's a lot of different ways that it can be measured, but we'll see differences in connectivity. And then, I mean, you have a slower brain, so you have increases in the slower brain waves, like delta. So you're going to see, somebody that's chronically abusing alcohol, you're going to see increase in delta, but it's so complicated because what if they're abusing alcohol and then 3 days before you want to test them, they stop, and then you're going to see withdrawal. And then it's going to be an erratic EEG. You're going to see more like spike and wave type.
Well, according to the information I found, that's not the case. According to information, what I found is people with addiction, doesn't matter what kind of stage they are, they have significant changes. There's more significant like theta waves and less alpha waves. You can see. It doesn't matter what kind of stage you see. You basically have to treat it in the approach.
But you don't know if they're intoxicated or not, because intoxication produces the same effect there.
Yes, exactly. Well,
right? So that's why I'm saying it's kind of complicated. Like because you don't know if they're in a state of withdrawal, if they're in a state of intoxication. I mean, right? You're talking about people that are being measured while
you have to use more, chemical tests, like different type of tests to figure out.
People who are chronic alcoholics have lower posterior alpha volt power, so they tend to have lower alpha in the back of their brains, tend to go towards more slower waves. But then, as I said, if they're withdrawing, they're going to be in probably a higher, faster wave pattern because they're craving that drug and they're unable to relax and calm themselves down. So that's a tough one.
That's interesting, but
it's
that's
not as
very
straightforward.
It's very interesting. See, the thing is, when we're talking about like psychiatrists, when psychiatrists during their like work, they deal with different type of patients. But it's very important to know. Sometimes you can discover a lot of things. Sometimes people can come to you with the one issue, but then you just figure out that it's absolutely different direction. It's an absolutely different issue that the person is actually dealing with. So let's, because time goes really fast. So I would like to really conclude that the complications can be like, we can discover a lots of interesting and complicated things. There are multiple reasons behind every single mental neurological disorder. And that's why it's so important to use medical grade devices and use a team, right? It's so if we're like assessing or using in one limited scale and like in one particular office, it will not provide appropriate results. You have to have a professional team that will able to provide feedback and help you with the actual evaluation, right? As I understood, your company is actually dedicated to it, right? Your company?
Me or Dr. Goldstein?
Dr. Frederick, I'm talking to.
We want to deliver the best quality EEG neurofeedback treatment recommendations that could be available for anyone to help people's loved ones. Yeah. And I'm going to say, like, do you cook? Do you like to cook?
Yes, sometimes, yes.
What kind of knives do you use?
Oh, different. Because
exactly,
we have from Japan. I mean, there's knives.
And does the knife in an unskilled person make a better dish than you, who knows how to make the dish? No. So I think that people get focused on what type of equipment and not who's using it and how much expertise they have. So, like, I think Dr. Goldstein has really, you have a system that does medical grade EEG acquisition, right? But if somebody doesn't know how to use it or place it properly, we're going to have junk data.
So your recommendation is to be very careful with choosing the right people who would do it and have professional team who would evaluate the results.
And the right equipment.
Right equipment. And basically, it's more complicated. I thought, honestly, when I was organizing a workshop, we were simplifying things for people, and we're just. Is there any? Can you give us recommendations in terms of maybe there are, like services, companies who does the job the best, who would provide this type of services for psychiatrists?
Well, I think BrainBit makes very good EEG equipment, and I think Myneurva is a great company for the delivery of remote EEG services, QEEG services as well.
And I think from education point of view, so psychiatrists, from neurofeedback courses point of view, I recommend True Bear Academy and Successful Practitioners. Couple of companies who provides training, education for neurofeedback.
And you literally have to, I'm pretty sure that you have to really have a really great team in terms of like evaluation of the neurofeedback. So it should be like professional people with different type of backgrounds, right? I mean, with different concentration in MD. We mentioned that it can be like when people come with depression, it can be just simply audio issue. It can be tenacity.
Do you mean for the initial evaluation?
For understanding, for interpretation of the signal.
I don't know why any patient would not go to an MD for their initial or for their mental health evaluation, because they're going to look at the medical causes, the biochemical causes, all of the underlying causes as well. And then if then the person is appropriate, know where to send them to get audiology treatment like you're going to speak to tomorrow, or EMDR therapy for trauma, or physical therapy like for Parkinson's. There's so many different occupational therapy. So there's so many different modalities. And, I think that probably ChatGPT is not yet at the caliber of a medical doctor in being able to take all of that into account, especially someone I saw today came, really very upset about the child who's picking their skin and is diagnosed with obsessive compulsive disorder. But there's a neurological obsessive compulsive disorder called PANDAS, pediatric autoimmune neuropsychiatric disorder associated with strep. So for anybody, to me, that's being treated with OCD and has a child that hasn't been looked at for that and examined for that, I mean, it's really a shame.
Well, we can say for sure that it's more. Well, we have to be like really careful and approach any issue like with holistic way, because the reason, as you mentioned, the diagnosis can be absolutely different, and the reasons behind of it can be absolutely different. So it's very good to have the team of professionals, different type of background. That's what I really would like to say. So let's put the people who maybe some of the present people would like to ask questions. Hello, everyone. Do you have questions? Maria, no? No?
This is Dr. Vittori, Dr. Boscarello, Dr. Kano.
Would you like to add something? If you have like something special to add to the subject matter? Is it like seems something interesting to you? Maybe there's something we didn't discuss, because honestly, my goal as a founder of Human Brain Expo, I'm trying to like bring different type of professional, discuss different type of subject matter in this easy question answers workflow, because usually doctors, they're not accessible. It's very hard to get information we need. If we have very interesting subject matter, which is very popular, it's very hard to get like real-time answers. And we're here to provide this type of services, just basic access to the information, access to the real doctors, access to the data people need. So Daniel, Karen, Alberto, do you have any questions? Maybe you would like to add, maybe you would like to comment or recommend something. No?
In terms of recommendation, I don't think I can really speak on recommendations or questions. Nothing really comes up right now, to be honest.
Okay. Well, we probably can contact Dr. Frederick if you need something in the professional settings. You basically can send email. You have basic LinkedIn contact of Dr. Frederick and Dr. Boris Goldstein. You can ask them directly in the chat, in the private messaging, for sure. Okay, thank you so much. Thank you so much. For me, I found a lot of interesting aspects. Let's put it this way. I discovered a lot of interesting things. And thank you so much for bringing so much knowledge, details. For me, it was very interesting. I believe that helpful for a lot of people. Thank you so much for being with us.
Thank you so much. Pleasure.
Okay, thank you.